I'm going to start off talking about PARP inhibitors in breast and ovarian cancer as a model for personalized medicine. No disclosures here. So we're going to try these audience response first time, so we'll give it a shot here. So this is a POP quiz to start, and or a PARP quiz, and if everyone can answer this question. PARP inhibition works on cancer cells by increasing apoptosis, restricting tumor-induced angiogenesis, interfering with DNA repair, or poisoning the spindle apparatus in mitosis. Okay, the answer is number 3, interfering with DNA repair. All right, questions. These are true statements regarding triple-negative breast cancer. That's TNBC. So triple-negative breast cancer, commonly seen in BRCA2 mutation carriers, tends to relapse early. PARP levels tend to be high. And I wanted to make sure that everybody drank enough coffee, so we're going to make a real complicated one. Is it 1 and 2, 2 and 3, 1, 2, and 3? All right, so everyone voted for 1, 2, and 3. And the correct answer is actually number 5 rather than 2 and 3. So as you'll see, triple-negative breast cancer is commonly seen in BRCA1 mutation carriers. Okay, and these are questions regarding PARP inhibitors in cancer. Sorry, you can't see the top, but so which of these is true for PARP inhibitors, the data that we have so far in cancer? They're effective only in the presence of chemotherapy. They can only be combined with platinum-containing chemotherapy regimens. They seem to prolong overall survival when added to combination therapy compared to chemotherapy alone. Or they are effective but have significant toxicity, making clinical development difficult. Okay, so very good. People have been following the literature, and 2/3 of individuals voted for the answer, which is overall survival, and that's some new data which I will show you, which actually just came out about a month ago. So this audience, as I expected, is very savvy on this. So let's move into this. I said I'm going to use PARP as an example of personalized medicine. And the old paradigm for cancer treatment is one size fits all. We would use one type of chemotherapy for any given disease, and we would base it on the histologic variable of what the disease was. And that is just simply been turned on its head now. We have a new paradigm for cancer treatment, which goes under the term of personalized medicine. It's probably in danger of becoming a cliche already, but it is a real phenomenon, and personalized medicine is based on adapting risk to different groups of patients. In large part, although not completely, it can be guided by changes in genomic expression in cancer, and certainly will go beyond genomic expression as we learn more. But the idea is to tailor it for individual patients, and so that you can imagine a future where every patient gets a recipe which is tailored based on characteristics that are present in the cancer as well as in the person. And the whole goal of personalized medicine is to make a greater impact on the disease. Now, we have examples of successful personalized cancer therapies already, and arguably the drug that set this field into motion was imatinib, and as a specific inhibitor of a specific chromosomal translocation that occurs in actually several diseases, but first in CML. More recently, we have erlotinib, which seems to work best when there's a genetic mutation in the EGFR receptor. And of course, everyone is familiar with trastuzumab, which works in a different setting of gene amplification of the HER2 gene and protein. So they're already in the clinic, but still are relatively specific. And they're very good examples and light the way for where we should go. So we need to look at relevant biomarkers in every disease. The problem is we don't have biomarkers in every single disease, and certainly many diseases we still can't subset genetically or proteomically to find what the target might be, but that is the goal. And the idea would be then, once we have a target, develop a drug to that target, design innovative trials to compare marker-guided therapy to standard therapy. And I hope to convince you that even in this relatively early phase of development of PARP inhibitors, we do meet the criteria for a new method of personalized medicine. So in order to talk about PARP inhibition, we have to go back to Molecular Biology 101 and talk about mechanisms of DNA repair. Now, it's remarkable that each of our cells in our body that divides has billions of base pairs that have to divide and replicate that DNA, the entire spelling of those 3 billion base pairs, every time correctly through a lifetime. And in order to do that, we've evolved to have a large number of mechanisms to repair DNA. And the reason is that DNA is constantly bombarded by a number of factors which cause abnormalities in the DNA and the readout in the base pairs. And that includes environmental factors. We're exposed to radiation all the time in our modern life, of course, chemicals. And of course, as we age, DNA changes and replication can change. Our experience, our therapy is based in large part on damaging DNA selectively in cancer patients and cancer cells compared to normal cells, and that's what chemotherapy do. And it's probably a misnomer to not say that our classic drugs in cancer, like alkylating agents and antimetabolites, are not targeted therapies. They most certainly are targeted therapies, but their target wasn't really clearly understood till lately, and their target is to a large extent, a number of ways of interfering with DNA replication and damaging DNA. So our bodies and every cell in our body have a whole host of repair mechanisms, and we can repair different types of damage to DNA, which includes single-strand breaks, and two ways that's done is with a mechanism called nucleotide excision repair and base excision repair, and I'll focus on BER, base excision repair, because that's where PARP inhibitors work. And then there's also double-stranded breaks, and I won't go into much detail here, multiple ways to repair that, but the most important is probably homologous recombination, and I highlight that because that appears to be where the BRCA1 and 2 genes work. Now, we usually think about BRCA1 and 2 in terms of the mutation associated with it, but these genes are DNA repair genes, and they function in normal cells in that fashion. And then there are a number of other ways that DNA can be damaged with a number of different mechanisms, but again, you'll notice that PARP is important in removing DNA adducts like occur with cisplatin and replication lesions. So PARP stands for poly-ADP ribose polymerase. It has a key role in single-strand break repair, as I said. It binds directly to sites of DNA damage, and once activated, it uses a small molecule NAD as a substrate, and what it does is it generates these large branch chains of poly-ADP ribose, which target these proteins. And these proteins here in the colors are DNA repair enzymes. So it basically attracts enzymes and it activates these DNA repair enzymes. So what happens? You get a single strand break, and PARP comes in and starts putting in these PAR molecules, attracting a variety of DNA repair. And what happens is if you inhibit PARP, none of these enzymes can come in. The single strand break then becomes double strand break. And when the cell goes to replicate itself, the cell dies because it doesn't have adequate DNA. Well, can't we repair that? And the answer is yes. There are, as I showed you, there are mechanisms to repair double-stranded DNA breaks. And this cartoon focuses on the fact that the BRCA1 gene is one of a host of DNA repair enzymes that repair DNA double-strand breaks. And BRCA2 plays a role in one of the mechanisms, which again is called homologous recombination. So if you're lacking BRCA1 or BRCA2, what happens is these cells become deficient in repairing homologous recombination. And if you've already inhibited PARP and then you inhibit BRCA, you have a problem with the cells. And that's shown schematically here. So the concept is you need to inhibit both of these key enzymatic DNA repair mechanisms in order to get cell death, a concept that's been referred to as synthetic lethality. So if you have one, here's a BRCA deficient gene in normal. So if you have, for example, a patient who has a mutation in BRCA1 or 2, their normal cells have one functioning copy of BRCA1 or 2 and one abnormal one. And so if you have, and that's relatively normal tissue, you get DNA damage and you inhibit PARP, they still have one functioning BRCA1 and the cell lives. In the cancer cell, of course, what happens is there's been the second hit phenomenon. So the cancer cells in BRCA mutation carriers don't have any normal BRCA1 or 2, depending on which one they have. And then if they get DNA damage, they get they don't have the BER through PARP, and then they don't have the BRCA, and they get cell death. So the idea here is you take the cancer cells are vulnerable because they don't have this repair, and then you add another vulnerability, and you end up with cell death. So I hope that's clear. So that's a good concept. Does it work? And I think the answer is yes, and this is the preclinical work that was published now about 5 years ago that shows very nicely that in cell lines, if you have a normal cell line or a cell line that has one mutation, heterozygous for BRCA1, and you add a PARP inhibitor, and there's a whole host of these drugs, you really don't get cell death until you get very high levels. But in a BRCA mutation cell line, that is would be the same as would be seen in a clinical cancer in a BRCA mutation carrier, where both copies of the BRCA1 is knocked out, there's a marked shift to the left, and these drugs are very good at reducing viability of cell lines, and it also works for BRCA2, as you see here, very similar curves. So in preclinical models it works. If you do it in established cell lines, in animal models, here's a tumor that's growing, and then you give a PARP inhibitor, you get killing of the tumor in the animal. So BRCA1 and 2 deficient cells are markedly sensitive to PARP inhibitors. That led to a host of clinical development, and as you can see here, there are at least 7 drugs from a variety of companies that are in development for PARP inhibitors. They vary in terms of their structure and the way they inhibit PARP. Some are IV and some are oral. I'm going to focus in the rest of this talk on the 2 that are most advanced clinically, which is AZD2281 or olaparib and BSI-201. One is an oral drug and one is an IV drug. So this past year in the New England Journal of Medicine, this exciting phase 1 data was published with olaparib for patients in solid tumors, a relatively small trial with expansion phase and an escalation dose. And the toxicities were relatively modest. These were patients who could have mutations or did not have to, but as you see, there were 19 out of 60 patients in this trial who had BRCA mutations. And 12 of those 19 patients, very heavily pretreated patients with a variety of cancers that had failed a variety of therapies, responded. And you can see that there were even CRs. And this was true for breast and ovarian cancer, but even prostate cancer patients who had a BRCA mutation had potential responses after heavy pretreatment. The toxicity was relatively modest and was predominantly GI in nature. So that led to a phase 2 trial of olaparib in BRCA-deficient metastatic breast cancer. This was reported at ASCO last year. Patients were eligible if they had a confirmed BRCA mutation and had locally advanced or stage 4 disease and had failed prior chemotherapy. This was a non-randomized sequential cohort study at a high dose, or the maximally tolerated dose of 400 milligrams BID daily at 28 cycles, or a lower dose at 1/4 of that dose. And the primary endpoint was response rate. Patients at the lower dose were eligible to cross over to the higher dose if they did not respond. The patients there were 27 patients in each arm of the study, so still relatively small. Again, all the patients had either a BRCA1 or 2 mutation carrier. About half the patients in both arms were triple negative, and there were patients here that had ER positive phenotype as well as HER2 negative. So all the different phenotypes of breast cancer were expressed in these patient groups to a lesser or greater extent. In terms of the toxicity, the drug as a single agent was relatively well tolerated. Grade 3 toxicity was seen significantly at the highest dose, mainly for fatigue and nausea and vomiting. Lower dose, very uncommon there. And a few patients got mild to moderate headaches and constipation as well.